So our next panel, we're going to do this switch live. The panel's up there. Mentally, this is my, am I allowed to say Young Turks panel or Doctors of the Future panel or youngish clinical leaders panel. These three physicians all are you going to kill yourself, guys? They all have played important system roles and are playing important system roles Sasha mentioned the virtual ward research that Irfan is leading. Samir, of course, recently produced the senior strategy, and Michael at ISIS in a leadership and scientific role, both. In the interest of time, I will turn it over immediately to Irfan, and we'll keep going. Oh, you should follow Irfan on Twitter, too.
Thanks. I think we are the only panel that decided not to use slides. Maybe a sign of laziness. But one of the risks of going this late in the day is that you'll just repeat everything that has been said before. And so to avoid that, actually not just to avoid that, I thought I would start by reading you an excerpt from an email I got a couple of weeks ago from a colleague. His wife's stepfather had advanced lung cancer. He actually died just yesterday. And my friend wrote, "These past few months have been filled with more mixed and indirect messages than you could possibly enumerate, to the great detriment of a man who has lived these months largely uncomfortable, having powered through 9 terrible weeks of gemcitabine and cisplatin, only to then develop intractable pain for which no one assumed the responsibility for management. Only 2 people in these 4 months ever suggested he was dying, me and one of the CCAC nurses who came in. There's a family meeting tomorrow which I assume will make that quote-unquote official. The CCAC was a rotating group of nurses without a coherent plan. There was no doctor in charge. This poor man and his wife didn't know who to call for anything. When they were first triaged by the oncology group, they were seen by 4 physicians, a social worker, a pharmacist, and several nurses. And the first person who visited them at home had nothing to do with any of those people. No one identified themselves as the ultimate decision maker. The family doctor didn't know their role in the whole thing. The lack of a, quote, boss or identifiable person in charge has been a huge issue, end quote." Someone last night said that e-health in Ontario has gone from being a scandal to being an embarrassment. I would put it to you that the way we take care of people who are in the 1% is an embarrassment, and I worry that we are en route to it being a scandal. You know, when you hear a story like this, it sort of seems obvious what patients who are in the top 1% need. And it goes back to what Francis Peabody said almost 100 years ago, I think, at Mass General, when he said the secret in the care of the patient is in caring for the patient. And we seem to have lost that sometimes. And, the person who cares for the patient, could be a doctor, could be a nurse, could be a family member, might be a team. I'm not sure the professional designation is all that important. But that person or team does need access to resources. That person or team needs backup coverage for weekends or evenings. That person or team needs to work within a system that, as Duncan Sinclair pointed out, we don't really have today. And that person or team really needs to be held accountable for the quality of care that the patient receives. So I would put it to you that this need is fairly obvious, but translating this need into measurable improvements at the system level has proven to be very, very difficult. And let me just give you one example. In the U.S., a couple of years ago, there was a paper published in the Journal of the American Medical Association, a report of 15 separate randomized trials of care coordination initiatives. We've talked a lot about care coordination today. So 15 separate randomized trials. That's like an enormous undertaking. 13 of the 15 showed no difference in healthcare utilization metrics. One of the 15 showed a reduction, and one of the 15 showed that healthcare utilization actually got worse. And none of the 15 produced savings. And everyone can point to examples of interventions that have worked. I could rhyme off a few: the care transitions intervention in Colorado, health quality partners in Pennsylvania. We've heard a few others earlier today. But in almost all of these cases, these interventions have depended on people really caring, and what sometimes can be seen from a detached remove as almost heroic efforts of a really small number of people. And very few, if any, of these interventions have proved to be generalizable across large systems. So I'm not sure that the lessons for health links in terms of how do we care for the 1% and 5% are all that obvious as we might hope. And I would put forward a paradox that I don't know how to resolve myself, which is when you hear stories about the 1%, like the one I just told you, it sort of seems obvious what they need: better care coordination, people who care about them. But when you take a really hard, honest look at the data, like Sasha did in his presentation about 20 minutes ago, many of these interventions rarely produce the outcomes we think we want. And Don Berwick has a quote that I really like, which I think is relevant here. And he says, real improvement comes from changing the system, not changing within systems. And I think, we've heard a lot of optimism today about health links, and that's the reason why I, too, am cautiously optimistic. I liked Duncan's phrase about people sort of looking over the parapet from Hepburn Block, and I hope that they're sort of looking over the parapet thinking, how do we really change the system this time with health links? And if we do that, then that may be a step forward. But I think we also need to be honest and say to ourselves that we really are in the infancy of figuring out how to best take care of patients with complex chronic diseases. And I thought as an example, I would just talk a little bit about how we've changed the way we take care of patients with myocardial infarction or heart attack over the last 50 years. So I would argue there are two main reasons why we have largely succeeded in improving how we take care of people with heart attacks. First, cardiologists, more than perhaps anyone in medicine, embraced the use of evidence, and in particular the use of randomized trials to figure out what they should do for patients. Every new drug was subjected to an RCT. Every intervention was subjected to an RCT. Even complex treatment strategies were subjected to RCTs. Even the whole coronary care unit was subjected to an RCT. Cardiologists have embraced evidence-based medicine, and their patients have really been rewarded for it. And at the same time, the public health community has had a massive and ongoing campaign to reduce smoking rates, reduce animal fat intake, increase activity, and diagnose and control hypertension. And I think it's hard to know which of those strategies has been more important. I'm not sure it really matters. But together, those two strategies, a public health focus and a relentless focus on high-quality evidence to guide treatment, has actually, I think many people are unaware of this, but it's actually reduced mortality from coronary artery disease by 75% in the last 50 years, which is it's truly stunning. And, for all we talk about the healthcare system not working, the fact that we've actually reduced mortality from coronary artery disease by 75% in half a century is a stunning accomplishment. So, Will asked us to talk about what services the 1% and 5% need, and I think that it may be that that's really jumping the gun a little bit. And two questions that I put to you that might be better to answer are, one, what population-wide strategies will reduce the risk of people entering the 1%? Recognizing there's a mathematical tautology there that I'm glossing over, but I think you know what I mean. Some people talked about social determinants of health this morning. Kathy Fuchs talked about housing. Duncan Sinclair talked about the social determinants of health. Alcohol and substance abuse are huge problems in this province, and we have a liquor control board that's trying to increase sales. There are really important social determinants of health strategies we could use to reduce the number of people who are in the 1%. And then the second question is, what methods should we use to rigorously evaluate how we are going to care for people who are already in the 1%? I think it's probably apparent to you what I think those interventions or what the answers to those questions are. I think we do need to focus on social determinants of health, particularly some of the ones that I've mentioned, and especially for the poor. We haven't really talked a lot about how many people in that 1% are poor. It's very difficult to figure that out using data at ISIS. But, for those of us who take care of patients, our sense is a lot of them are poor. And then when we're testing complex health interventions, particularly those that cost more money or have an opportunity cost that is substantial, we really should use the same methods, in my view, that we use for drugs and devices, i.e. randomized controlled trials. So I've evaded the question a little bit, Will, and I apologize to that, but I'll leave it to Michael and Samir to give you the real answer. Thanks.
So it's always a tough act to follow when you follow Irfan Dhalla, but it's a great topic because I think right now, as I've been traveling around the province, talking about the senior strategy, at the same time, people are really embarking on this journey of health links, which I think is, again, there's cautious optimism, but there's a real appetite right now for how do we figure out what this group needs and what do we do to deliver better care. So I want to bring a slightly different perspective to it, and given that I'm a geriatrician, I'm actually in the middle of my geriatrics clinic right now. Exactly, my next patient's coming at 3:45, so I have a hard stop because I'm not going to be late. Now, because this is the interesting issue. A friend of mine gave me a little bookmark the other day from a group called the Grey Panthers. I don't know if you heard about it. It's kind of a slightly militant group of elderly in the U.S. who are really fighting for their rights. And the bookmark says, "Aging is not a disease; it is a triumph." And I think we have to remember that because when we go back to 1900 in Ontario, life expectancy was 51 years of age. Okay, so I always hear a few gasps at that point because people start looking around and going, okay, I don't have much more time. But, when Irfan talks about, the success we've had with reducing mortality from that heart attack that would have killed Grandpa, now that we've reduced mortality by 75% in that area alone, we're seeing people living longer and longer than ever before. Now our average life expectancy in this province is about 80 years of age. And we know that once you hit 65, you have about 20 more years ahead of you. 17 of those years are in good health, but three of those years are not in so great health. And when we start looking at healthcare utilization in our province, if you just look at it from the aging lens, for example, so Walter showed you the data this morning, talking about the 1% and talking about the more costly age groups and so on. His interesting data set, which I really took interest in, was when he cut the data by the 65 and older, because we know half of our health and social care spending right now is accounted for by only 14.6% of Ontarians. Their numbers are going to double in the next 20 years. But interestingly, when you cut the data, when you look at Walter's work and you look at the data, we find that 10% of older Ontarians are responsible for 60% of their health care costs within the 65 and older cohort, but remarkably 50% of older Ontarians accounting for only 6% of their costs amongst all spending on health care. So the interesting thing that I look at is I know one thing that people are struggling with are the 1%, the 5%, who are those percent, and a lot of people are putting a lot of energy running around. Well, if you come to my clinic, I'll introduce you to all the members of the 1% and 5%. And there was some really good work. There's lots of great work that's been done, but there was some really good work that really changed my thinking as a geriatrician on who I had to think about. It means that I don't have to look through administrative databases because I just look for this pattern. Because this is the pattern that I see that defines, and this is what the literature says, is that 10% I talked about who costs 60%, 3 common characteristics. Number 1, polymorbidity, having 4 or more chronic health conditions. Okay? Number 2, functional impairments, problems with 1 or more of your ADLs. And as a geriatrician, our ADLs, as we measure them, are these 6 things you probably did this morning. You transferred from a lying to a standing position, you walked to the bathroom, you toileted yourself, you bathed yourself, you dressed yourself, and then you ate something. If you have challenges with 1 or more of those activities, we know that you're going to be in that group as well. And then the third factor is social frailty. So everyone has an iPhone. You might be Twittering here at the conference right now. You might be Skyping. I Skyped with my mom and dad last night. And so people say, what are you talking about? We're going to have Watson soon. We're going to be more than socially connected than ever before. But, at the end of the day, we are less likely to be living in intergenerational households today. We're less likely to be living in intergenerational communities. And, when my mom and dad who are aging in place in Winnipeg, with a son in Baltimore and a son in Toronto, if my mom and dad need groceries, I'm not around the corner to help them out with that. So when we start thinking about those aspects, when we think about that social frailty, which more broadly can be thought of as the social determinants of health that Irfan highlighted, right? Poverty, housing, transportation, access to community supports. When you start thinking about those characteristics of the population, that, I think, really, when you start honing in on those issues with those patients, you start really doing well with that patient population in particular and start matching the needs. So my piece of advice is, as people have been saying, well, what's the population we should focus on? Well, there's complexity in many groups. I often think of complexity across the population as children with complex health issues. I think about mental health, and significant mental health issues. I had a consult this morning, a 64-year-old lady who's been a chronic alcoholic. Her capacity is questionable now, and we're trying to figure out what's her disposition planning because she's had about 38 hospitalizations. She's currently at Toronto General in the last 3 years, for example. So again, thinking about mental health and other issues, and then thinking about those frail elderly, the ones who survived that heart attack, probably have had 7 now, a few strokes, maybe a touch of dementia, and then they're trying to figure out how do they navigate with those 3 issues in particular. So that's the lens I try and look at, and I think that's a lens that I think can be quite helpful. As we start trying to think about what are those issues of frailty and what are those issues that we can start thinking about, because then when we start thinking about what are the services that 1%, what are the services that 10% need, I think it starts becoming apparent. I think the most important thing that Irfan said is caring. Right? So it's, again, thinking about how do we actually figure out what people need. We know that the nice thing I really love, and I think David Naylor talked about this last night, was, a low rules environment, which is, I know, what Helen and others are talking about, is that environment where if we care, because often sometimes our caring is inhibited by, but we can't do that, or you need this form to do that. We have a really exciting opportunity through this initiative to say, what is stopping us from doing the caring that we need to do? What's stopping us from empowering that caregiver? Is it information? Because I know that when we actually surveyed 800 caregivers last year for the senior strategy, 50% of them said they don't even know what services CCACs provide. And I had another caregiver who wrote a letter to me and said, caregiving, Dr. Sinha, is a 24/7 job. So the thing is, if we're not making sure that person has the information to connect in with the embarrassment of riches of services that we provide, then we've got a problem. So how do we connect people with the information? How do we make sure they have the services? And then what are those models that are going to work well? And I don't think it is a cookie-cutter approach. Right? There's not something you can just pull off the shelf and say, this has worked well. We have to look at each of those models and then look at our population and say, is there a language issue? Do we need better translation services? How are we getting information towards patients? And then what are some of the things that we can easily do to change our practice that really, as Irfan was saying, changes the system? So I'll give you the last example, or 2 last examples. So patient right before here that I saw, a 75-year-old gentleman who basically has, I just gave him a diagnosis of mild dementia. And so he was saying, well, how do I stay healthy? How do I stay independent in my home? So I always do wellness and prevention. It's something I really focus a lot about in the strategies, about the importance of wellness and prevention, preventing people from becoming the 10%, the 1%. So I said, have you ever had a flu vaccine? No. Is that important? How about a shingles vaccine? No. How about a pneumonia vaccine or a tetanus vaccine? These are the 4 vaccines that all older adults should have, right? Didn't have them. But his diligent family doctor on the way to Dr. Sinha had done a stress echo, had done echoes, done a CT. I had a $3 million workup probably. But, these basic 4 vaccinations that are actually 3 of them being covered, under OHIP that are available, these are things that could, easily be done. So I always say, if you're trying to think of a one quick win strategy that you can do to really affect population health, especially amongst this population, given that it's not the influenza or the pneumonia that will necessarily kill you, it's the exacerbation of all those chronic illnesses that it will, the heart disease, everything else that will happen. My recommendation is, we know that last year in Ontario, 40% of older Ontarians had the pneumonia vaccine. 70% had the flu vaccine. But 10 years ago, 76% of Ontarians had the flu vaccine. Okay, they're not perfect. Okay, I'm not arguing about perfect efficacy, but we know the results. Things can happen. But when this is a low-hanging fruit sitting in front of you with this chronic population, this is something that we can just say every older person. Because we have a joke in my clinic: no arm is safe in my clinic. Right? You will not leave if you tell me the answer is no to any of those questions. You are not leaving without a sore arm, because we're going to make sure. But we know that we're actually impacting outcomes in that way. So thinking about those models and then thinking about what are the things that we can do for our population, because Irfan said, not all the evidence is perfect. We have to look at our populations, and there are some great examples of things that are happening across Ontario. I was witnessing that, of things that we know are actually helping to get better results, but they have to be individualized. We have to understand what are the local politics, what are the local resources, and what are the local opportunities. So thank you.
So let me first start by thanking Will for inviting me, and Longwoods for inviting me to talk here today. Will introduced us as the young and youngish panel, so I can assure you that Samir and Irfan are the young, and I'm the youngish member of this panel. So I start with a, you're never supposed to do this, but I'll start with a kind of an excuse or an apology that I don't really feel that I have any particular expertise to tell you what services the 1 and 5% need. I'm not like Irfan, someone who's organized and run a virtual ward, nor am I, like Samir, an expert in geriatrics. I'm an emergency physician at Sunnybrook. I still practice there. So I do see a lot of older patients who have a lot of complex problems, no doubt. And I guess if I was to be honest with you, the way I would answer that question is if we're really talking about the entire 5% across Ontario, what do they need? The answer is pretty easy. They need just about everything. Just about everything that our social and medical and mental health systems can provide. Because the 5% represent a variety of chronic diseases. They represent new diagnoses of complex diseases like cancer. They represent end-of-life patients and complex combinations of medical, social, and mental health problems that can interact in a variety of ways and require a dynamic response from the system. That is, they require pretty much everything that we have to give to them. So rather than answer exactly the question that Will gave me, let me take some liberties and talk rather about some of the principles that I think need to underlie the care that HealthLinks will provide to the 1 and 5%. And I use the word principles deliberately because we've heard a lot today about the low rules environment of HealthLinks. And I, like others, agree that we don't want to be dictated from on high, from Hepburn Block or anywhere else for that matter, exactly how we should organize our care. But I don't think we should confuse low rules care with care that is without principles. I think we do need principles. So what are they, in my opinion? Well, first, I think the 1 and 5% need a health link that can respect and strengthen their existing relationships with primary care and specialist providers when that's the patient's preference and when it's clinically appropriate. Now, it's true that existing patient-provider relationships may not be the best or the most cost-effective manner to organize care or manner in which a health link could organize care. But if you're not going to start with those, where else are you going to start? This is the system we have today, and I don't think anybody's talking about blowing it up. So I think we need to start with those existing relationships. Second, the 1 and 5% need a health link which has a defined patient population for which all parties in the health link are jointly responsible. At a minimum, this means that a primary care doctor, designated hospital or hospitals, and the specialists that work there, and community service providers jointly recognize an explicit patient roster as their joint and shared rooms, in their ERs, in their hospital beds, or on their waiting lists. We talked about the VA system, Kaiser Permanente, Intermountain, Geisinger, NHS, German health plans. If you look around the world at high-performing integrated health systems, a common denominator is a defined patient population. if you don't have a defined patient population to build a health link for, then for whom are you building the health link? Third, the 1 in 5% needs a health link that does not base its roster only on geography, especially in major urban areas. Which health link you belong to should not solely depend on whether you happen to live on the east side or west side of Parliament Street in downtown Toronto. This kind of approach is problematic given current health system utilization, as Therese Stuckel's ISIS work published this week in Open Medicine on virtual networks demonstrates. Fourth, they need a health link that can report to its patients, its providers, and its stakeholders on the quality of care being provided, which requires sharing of electronic health information efficiently and swiftly within and between health links. Barriers to this information capture and exchange need to be dismantled with great haste if health links are to succeed. And by the way, if you don't have that patient denominator that I mentioned a moment ago, don't bother trying to measure quality of care because you won't be able to do it in any kind of rigorous or comparable way. There's all sorts of ways you can do it, but it won't be rigorous and it won't be comparable. It'll be essentially meaningless. Finally, they need a health link that can identify the 1 in 5% before they get into the 1 in 5% categories. That is, that can identify patients at risk of falling into the high-cost, high-user categories. Because it's not clear that patients in the 1 in 5% categories today will remain there tomorrow, even without our interventions. Nor is it clear that we know how to improve quality and reduce costs for these patients. Greater benefits to patients and the health system may arise from preventing at-risk individuals from becoming high-cost, high-user patients in the first place. About 2 years ago, I attended another conference. Attending conferences always makes you think about other conferences you attended. It was an international conference on health system innovation. It was in Washington, D.C., and there were representatives from all the major OECD countries. I was there as an observer. And what was remarkable was that of all these countries represented, Germany, Holland, US, France, Canada, UK, Norway, Denmark, you name it, over 2 days, the one word that I never heard mentioned in any presentation was Canada. Canada was not held up as an example of health system innovation by anyone. While there were health ministers sent from many of these countries, or senior bureaucrats, deputy ministers, and so on, Health Canada sent a very junior bureaucrat who sat in the background and said nothing over the course of the entire conference. And one of the breaks, I went up to Uwe Reinhardt, who many of you probably know, a well-known internationally acclaimed health economist at Stanford. And I said, I relayed that observation to him. And he said something very interesting. He said, 40 years ago, Canada's primary care health system was the envy of the world. You were looked up to by so many countries and thought of as an example. And for 40 years, you've sat on your hands, and the world has passed you by. I think there's a real opportunity that these health links will actually succeed and will become a model so that the rest of the world can begin to look up to Canada again. But I think we can't be certain about that. And I think we will need to do this right. And I would argue that some of the principles that I've laid out are pretty key ingredients for their success. Thank you very much.
Thank you, guys. Again, a wide-ranging set of comments. I want to challenge you guys a bit to roll the clock forward here, okay? Because we are where we are with the first group of 19, and there's another set that are coming through. You've laid out pretty nicely the characteristics in terms of principles and evidence and particular interventions on seniors that you want to see. As we start seeing the results of the first round experimentation coming out, how will we and how should we be setting up the system to move into a more principle and evidence-based approach? If we accept the fact that what we're in now is experimentation phase 1, if you like, kinds of things, how will we take the results from the first group that have promise and turn them into something that's systemic and scalable?
I mean, I fully agree with Michael, and I think he kind of answered your question a little bit when he said, I don't remember exactly what he said, but if you don't measure it, rigorously or whatever, it's meaningless. And I worry a little bit that if we don't have defined populations, which I totally agree with Michael about, if we don't have defined populations, defined denominators, and we don't follow metrics for, periods of time, I'm not sure how we'll know whether the initial early adopter communities have been successful or not. And I would add one small thing about the populations that, to what Michael said, was that if health links focus on the 1% or the 5%, the other thing to remember is that those groups are continuously changing. And so if you're in the 1% in 2013, there's a pretty good chance you won't be in the 1% in 2014. So if you follow that same group forward in time, the utilization would be expected to go down. And if you look at that trend in the utilization and you declare success, researchers like Michael and Samir and I will look at those data and say, okay, that's fine, you declared success, but I'm not sure that really tells us all that much.
So I would add, your question was, fairly soon, how are we going to measure success and how would we scale? I think one of the problems that policymakers struggle with and that folks that have to run the system struggle with is the need for rapid decisions and rapid measures that this has worked or it hasn't worked. I think, these were announced in November, right? I mean, people have just started to get, organized. It's extremely early. A year from now, it'll be early days. No one is arguing with the fact that what people are talking about in terms of creating the relationships, bridging the silos and so on, these are not also critical ingredients to successful integrated health systems. I would never argue that. What we're talking about at the conceptual level for health links is absolutely critical to establishing high-quality integrated health care delivery. But it takes a few things more than that. So I think what I would like to see in 6 months, as these begin to mature, is that we begin to establish some of the, let's not use the word rules, but let's say principles, or let's say operating ways and means by which the health links should move forward and continue to be rolled out.
Well, I agree with you entirely. You have to have a defined patient population. Absolutely. There's no escape for that. But I haven't heard anybody mention, by way of measurement, patient satisfaction and the satisfaction of their families, which could be measured in 6 months easily. The rest, I agree, have to take longer. But that's an important measure that Kathy referred to this morning, and that can be started right away. It just takes a few phone calls.
I think just building on the previous comments as well, and then that comment is the idea that I think if Kathy mentioned earlier this morning about the Northumberland Path Project, for example, it's been interesting watching that develop over the past year, for example. That's kind of almost, a health link happening in that community. And it's stunning hearing a lot of the early news from that. But, my initial reaction was kind of, in that way that, so where are the results? What are we seeing? How many patients enrolled, et cetera. And, what I was told is it's been about a year. And after a year, we are just establishing trust and relationships. We just defined our population. We've really engaged the patients, and we've listened to patients and caregivers to understand what's going to define satisfaction and success in their view, what defines, caring, as Irfan said, and what are we going to use to, A, define our population, as Michael was saying, and then what are we going to measure success. So it's been about a year, and they said, we are just about to launch, but we're going to be prepared that when we launch, we have done our due diligence, we've listened to each other, we understand who each other are, who our population is, how we are going to measure success, and then we're hoping that a year from now, we're going to start seeing some results in some early days. I think the one challenge that I'm hoping for, and I know that Helen and the team have been working on this so far, is making sure that this is a learning collaborative as well. Because when I had the privilege of working with Dr. Walker and traveling around the province, we were, everyone's heard about the Home First Initiative, for example. And we were going to some places, Mississauga Halton started that back in 2008, And there were some LINs when we were coming around a year ago who hadn't even launched Home First, didn't even know how to start it up. And I thought, well, wait a minute. The 1-2 over from you has been doing it for 5 years. They've got all the toolkits. Here's their number, and duplicate. And I found that CCACs and the LINs, for example, didn't have as robust as I would have hoped kind of an exchange in a clearinghouse to really start changing, saying best practices or what worked in our communities. Because I think that's really, really important to make sure that that's a fundamental bit, because it might not be an RCT in year 1 or year 2, but we're going to need rigorous evidence. But we also need more than compelling anecdotes. We need compelling evidence, and we need to make sure that we share it even within our own province, let alone internationally as well.
Now, would I be unfair if I said that we've got a role reversal going on here with the folks at the parapet pushing hard and the Young Turks slowing it down? I mean, what's going on here? I mean, how do we? I mean, it's hard for me to imagine Hepburn Block as a force for progressive good, but aren't you guys going to slow this down?
So I'm not arguing
a whole bunch, or is this some path towards a learning system? I mean, I
don't think any of us have heard. I think any of us said slow anything down. We all would agree with the need for integrated healthcare, and as I said, the principles that underlie health links are exactly bang on what we need. But we need more than what I think I've heard so far. And the truth of the matter is there may be health links out there that are planning to organize themselves in exactly the way that I or someone else would like. Not that I have anything to say about it, but we just don't know. And I think that this is a moment, these are early days, but there is an opportunity now to shape these in ways where we will actually be able to determine that they are providing high-quality care, that they do provide great patient satisfaction, and hopefully that they actually lower costs. But without the ability to measure any of those things, we'll be hard-pressed to sit down a year from now and really know where we are.
I'm not in favor of slowing things down. In fact, I think the excitement that's out there and that was palpable, or that is palpable in the room, comes from the fact, one of the reasons for the excitement comes from the fact that people who perhaps have felt like they haven't been consulted all that much about health care in Ontario over the last generation or two, in particular primary care docs and community care providers, feel that this time around they're being consulted. And that is really powerful. But I think, as Duncan pointed out at lunchtime, that needs to lead to a real change in the system and not just us saying that there has been a change in the system.
So when we talk about the top 1 or 5%, we're often implying that these are high users. But in fact, they're not users. They're often takers of care. And folks like you are providing that care. They're often not asking for it. And we've talked a lot about better access, better integration. But what advice would you have for the health links around systems and structures to ensure that there's more appropriate care being provided at the patient level? We can evaluate the concept of health links and whether they're effective at an aggregate. But what can health links do to ensure that the care that is being provided is more appropriate?
I want to build on one thing that Michael had talked about is that, the care of a patient can't end at, you can't be a silo. It can't end at the family practice level. It can't end at a hospital level. And, I'll give it some, international example, then a local example. When I was in Britain, they were experimenting with primary care trusts. They're now on to GP commissioning again. But the interesting thing I saw was I got to evaluate a novel model called care trusts. This was going beyond primary care. And this is where you actually allowed the local authorities to say, let's pool our housing budgets. Let's actually pool our health and social, like our social services budgets. Let's pull it all together in one pot. Ambulance services, everything together. And all of a sudden, when everyone started saying it's not, because there was a whole fight, if you read the British literature, about is it a social bath or is it a health bath? Because if it's a health bath, the NHS pays. If it's a social bath, then you pay on a means-tested basis. It's just ridiculous. But when you pooled all the money and you said, this is our shared responsibility, these are our patients, these are our responsibilities, and the patients are engaged as well, you start actually seeing a change in thinking. You start seeing shared ownership and then shared risk as well. Locally, one of the most powerful things that I saw, just as a local example with our group, and I think it's happening in Northumberland, was that, Mount Sinai was quite an insular organization, for example, around the care of older adults. We would, you come through our front door, the Emerge, and then you'd leave through, hopefully, the front door again, and we'll maybe see you next time, right? Well, we started partnering with groups like the CCAC, for example, with our highest risk patients, or with a house calls program in the community, for example, who had patients who were often using our services. And by saying, this is our shared population, we have a little thing that we did in our system where we have a little email alert. So if that patient ever shows up at the emergency department, we've got 20 people on the email alert. CCAC care coordinators, the primary care providers, the people on the Emerge, the people on the wards, and immediately we're all texting each other saying, wait a minute, all secure, by the way, all through one mail, but the key is we're all email, and we're having a virtual case conference because we're all taking responsibility, and we're all sharing in the care of that patient. And I think, again, we want to rigorously evaluate because that's important to see, is this actually having a difference? But the goal that we're trying to do there is, again, taking a shared responsibility for a high-needs population that, as Brian said, aren't necessarily seekers of care, but are takers of care due to their situations.
David?
Thanks. So Samir just touched on it briefly, but I wanted to be a little pointed and maybe have a discussion a little bit around what patients want around privacy, because we've heard a lot about the lack of communication between care providers or even between care providers and patients. And I'm wondering if we've had a frank discussion whether or not, and I'm a bioethicist by training before I did medicine, so I hold the 4 principles of bioethics dear to my heart, and they're mid-level principles that we've all agreed to in the system, right? But I'm wondering if we're married to 20th century concerns over what patients in the 20th century were worried about around privacy, and if that's hindering our ability to care for very, very complex individuals. And partly it's only because we're all in different. We have a system where we have local governance at every single institution, and so you need to have, as you heard from my colleague here, Lisa, a data sharing agreement to even discuss who the high users are between CCAC and a hospital. Is that really what patients want? And is that maybe one of the really frank discussions that the 400 of us need to have in order to move this forward in a really fundamental way to deal with this communication gap that patients are telling us is really the issue?
Last comment from each of you.
So I think it's fair to say that patient confidentiality and security around personal health information is absolutely essential, I think, to underpin the credibility of a health link or a hospital for that matter. If scandals, if they do occur, will do a lot to undermine a health link as it's getting started. Having said that, I do think that there's too much made of this, too many barriers put in place. There is a sort of privacy police out there that see threats around every corner. And, as a clinician, I've never had a patient complain to me about many conversations that I've had with them in hallways because there was nowhere else to put the patient in the Emerge. Of course, you moderate what you say and what you ask and how loud you say it and so on. But the point is that patients want care. They want proper care. They understand the need to communicate, and they understand the need for teamwork. So I do think that this has become a major barrier to providing good care and also to providing good evaluation or analysis or just ongoing monitoring of care.
So what's the fix?
Well, that's
ways and means, right?
There's probably the need for a conversation. There's probably a need to empower patients, to educate patients and ask them, what do you want? What do you see as being acceptable? And have the people who are making the rules listen.
This is something I heard so often over the past year from providers and patients and caregivers, and my patients even saying, get over yourselves, right? They just assume that when you're one of my patients, Irfan's patients, one of Michael's patients, they just assume the primary care doctor shared the information with the ED doc, that the hospital is sending information to the primary care providers. And we all know as providers how encumbered we are when we have no clue what happened in the magic box of the hospital, what's happening in the magic box of long-term care, or the magic box of the CCAC, etc. I have patients all the time who are saying, why did I get reassessed? I just moved across the street. Wouldn't that care coordinator have more time to care for other people? And this is my 83-year-old demented patient, told me this 3 weeks ago. Okay? So I saw too many, and I wrote about this very subtly, but it was quite firm what I was talking about. You know, again, we have systems like the IAR, the Integrated Assessment Record, but we have certain agencies who say, well, I don't know if my information is as trustworthy. You know what? Get over yourselves. We should all get over ourselves, because frankly, when I show patients the email saying, you know, these are the conversations, they're so proud, because they're saying, oh my God, you're caring for me, and I really appreciate that.
I won't talk about privacy because I don't know anything about privacy. I try to avoid that czar at my hospital. But I thought I would maybe touch on Brian's question about what patients need. The most frightening thing I heard, I think, today was that Watson is coming in 12 years. Because I hope I could still say that I'm youngish in 12 years. And if Watson really replaces me, then I'm not sure we'll be able to retire. But I don't think Watson will replace physicians, because I think one of the central challenges for healthcare in the 21st century is we know that we need standardization. Right? So patients who come into the hospital with an acute myocardial infarction or stroke, Sasha talked about, they need a standard process. But at the same time, there also needs to be a high degree of customization. And often that customization can only be provided by somebody who really knows the patient well and who the patient trusts. And more often than not, that's the patient's family doctor. And so, maybe Watson will replace me. I'm not a family doctor, but my wife's a family doctor, and I know it won't replace her. So we'll have her, and we'll
hire Watson in geriatrics, because we need a lot more geriatricians if he wants to come.
Okay, well, thank you three very much for a very productive and provocative session. I appreciate it. And